Welcome to Multicare Ear, Nose and Throat Sinus series. And today we'll be talking about functional endoscopic sinus surgery in a child. KI is a 6-year-old girl with left eye swelling, watery eye, nasal discharge. Examination revealed left eye swelling, watery eye, engorged turbinates. You can see the left eye swelling there with inferior proptosis highlighted in the blue cycle. And this is a reconstruction showing a defect in the laminar papyracea. You can see the defect there being highlighted in a blue cycle there. And this is a CT scan showing isodense lesion in the ethmoid and obstructing the osteomeatal complex. An MRI shows this is either a mucosal or a pyosal. The same MRI showing involvement of the ethmoids and the frontal recess and the frontal sinus all involved. And this is an intraoperative view of the child. Engorged bluish inferior turbinate. You can see the middle turbinate, the inferior turbinate, and the onset process is fused to the bulla there, and we can hardly have a space to introduce a probe there. So you can see everything being frozen there due to chronic inflammation. Now we'll do our medial meatal antrostomy, and it's quite difficult even insinuating a backbiter forceps. But we managed to get the backbiter blade into the region of the infundibulum. And we now proceeded with the retrograde medial meatal antrostomy. We took more bites into the frozen onsenate process. We now use a RAD 40 microdebrider blade, 3.5 mm, to debride away the horizontal portion of the onsenate process. More of the debridement. And then we use the spoon curette to try to evade the onsenate process. And you can see it's all frozen on the bulla. But we managed to get some tips out and then debrided away some portion of the onsenate process in order to give us an excellent view into the medial meatal cavity. And in order to free up more space, we decided to take some bites into the face of the bulla ethmoidale so as to do some limited ethmoidectomy. And boom, you can see we've gone into the lesion there, and that's a purulent collection in the region of the bulla ethmoidale. So we suctioned out copious amounts of pus from the ethmoid cavity. And you can see the ballooning of the ethmoid cavity being shown. We suction more of the mucoid purulent discharge. And we decided to take down the horizontal portion of the face of the bulla. And we can have a view into the frontal sinus, that is the anterior table, and the posterior table of the frontal sinus. And that is the region of the anterior ethmoidal artery, posteriorly there. And that is the lamina papyracea lateral. So we decided to take down the horizontal septation of the ethmoids and the bulla in order to give us more clear view into the ethmoid cavity, and also to expand the ostium of the maxillary sinus. We took down more of that septum using a baby true cut forceps. And we need to be a bit careful as we get towards the area of the skull base, because the optic nerve tract could be exposed after that last posterior ethmoidal saw. And you can see this exposure gave us more access into the ethmoid cavity, and we identified a locus where some pus was collected. You can see the defect there in the lateral wall, and you can see pus oozing out from that pocket there. More pus being exuding from the ethmoid cavity. And we decided to probe that blind pocket carefully, because that is the region of the cribriform and the area where the anterior ethmoidal artery runs. And we do it gently in order not to run the risk of fracturing the skull base with inadvertent leakage of cerebrospinal fluid, or even injury to the anterior ethmoidal artery, which could rather complicate a simple procedure like this. That's the anterior ethmoidal artery around the region of the 1 o'clock position on your view there. And that's the region of the lamina papyracea. And you can see the defect there in that hyperemic area. You can see the Stankovic sign showing a positive sign due to defect in the lamina papyracea, which we earlier highlighted on the CT scan. Now we irrigated the surgical cavity copiously with saline and steroids, and then we remove every bony spicle hanging in the operative field. Now there's a clearer view into the left nasal cavity, the inferior turbinate, the medial turbinate, the choanal, the ballooned out ethmoidal cavity, the laminal papyracea, maxillary sinus os, and we decided to irrigate the cavities with concentrated dose of methylprednisolone solution. And that is the operative view there. You can see transmission from the nasopharynx. And we decided to suck out the excess fluid from the area of the nasopharynx in order not to choke the patient avoid choking the patient during recovery. Thank you for your time, and thank you for